Hello everyone. At the outset, I would like to thank Team YOSI and Team Ocular Emergency and Trauma for giving me this opportunity. So today we'll be discussing about sympathetic ophthalmia. Sympathetic ophthalmia is a bilateral diffuse granulomatous panuveitis which presents post-penetrating trauma or surgical procedure in the contralateral eye, which is also known as the inciting eye. It presents within 3 months in 80% of the cases and within 1 year in 90% of the cases. It is most commonly reported post open globe injury or vitreoretinal surgeries, although it has also been reported post cataract and glaucoma surgeries, cyclodestructive procedures, and rare procedures such as resection of iridociliary melanomas, proton beam irradiation, and even post squint surgeries. Let us discuss a few case scenarios. The first one was a 26-year-old female who presented with trauma to the left eye by a goat's horn for which she underwent tear repair. She then presented 6 weeks later with decreased vision in the right eye. The fundus photograph shows multiple neurosensory detachments and an hyperemic disc, while the fundus fluorescein angiography revealed multiple pinpoint hyperfluorescent leaks. The OCT showed multiple neurosensory detachments and a bacillary layer detachment. A diagnosis of sympathetic ophthalmia was made and she was administered intravenous steroids followed by oral steroids and azathioprine. There was subsequent resolution of signs and improvement in the vision. The second case was a 23-year-old male who presented with a sclerocorneal tear post drone blade injury. He underwent emergency tear repair and presented with other eye diminution of vision 1 month post trauma. The OCT again showed multiple neurosensory detachments and a bacillary layer detachment. He was also initiated on intravenous methylprednisolone followed by oral steroids and azathioprine. The subsequent OCT shows the resolution of the neurosensory detachment and the bacillary layer detachment. Coming on to the management of sympathetic ophthalmia. Preventing sympathetic ophthalmia is of paramount importance, for which immediate and meticulous wound repair post-trauma is essential. Also, post-operative oral steroids help in controlling the inflammation. Early detection of sympathetic ophthalmia can be done by monitoring visual acuity, including the near vision in both the eyes post-trauma. Also, dilated fundus examination and explaining the warning signs to the patient is also very important. Once sympathetic ophthalmia is diagnosed, pulse therapy of methylprednisolone intravenously 1 gram per day for 3 days is administered. This is then followed by oral prednisolone 1 to 1.5 milligram per kg per day with slow tapering over 2 to 3 months. Simultaneously, immunosuppressive drugs such as azathioprine or mycophenolate mofetil should be administered for a minimum of 9 months to 1 year. Once there is an improvement in the clinical condition, azathioprine or mycophenolate mofetil can be continued. However, in refractory cases, other immunosuppressive agents such as cyclosporin or cyclophosphamide can be considered. If the patient responds to these drugs, then cyclosporin or cyclophosphamide can be continued. However, in non-responding patients, biologicals should be considered. While administering immunosuppressive drugs, it is important to monitor the blood counts along with the liver function test and kidney function test every 2 months. These are a few textbook chapters and a few articles for further reading about sympathetic ophthalmia. Thank you for listening.